Alors, merci beaucoup pour votre introduction et aussi merci Jérôme pour m'avoir invité, mais je ne suis pas capable de faire cette présentation en français, alors je le fais en anglais. So, next slide, which would be, right. Okay, so a couple of years ago, we were asked by the European Rare Disease Network, the ENDO-ERN, to do an experience on patient experience within one of the work packages of ENDO-ERN. And that is what I'm going to explain to you today. And we went on to learn what patient journeys are. They were developed by one of the ERNs, Genturis, which is devoted to genetic tumor risk syndromes, which are inherited disorders and strongly predisposed to the development of tumors. These diseases share similar challenges with many other rare diseases: delay in diagnosis, lack of cancer prevention for patients and healthy relatives, and therapeutic challenges. And to overcome these problems, this ERN of Genturis developed an innovative visual approach for patient input into the network so that they could share their expertise and experience. And this is what is known as the patient journeys. In a way, it's a patient-reported experience measure, which nowadays are considered very important to assess the quality of healthcare in the different countries. And they, in some diseases, have even been shown to be predictors of survival. And what these experiences have shown, that if patients are involved in the design, evaluation, and designation of healthcare services, this improves the relevance of the tools used, as well as the quality, and they can, in a better way, meet the patient's needs. So essentially, to be able to involve patients right from the beginning and discuss with the healthcare providers their problems and needs is something that is desirable, but is still not available in many centers or from all diseases. So patient journeys are instruments which were developed by Eurodis, which is the voice of rare disease patients in Europe, to collect patient experiences, and are capable of identifying gaps and areas that deserve improvement, as well as positive aspects that the patients consider good. As a patient-reported experience measure, they can complete the clinical evaluation and management of a specific disease or group of diseases. And hopefully this will improve the diagnostic delay, improve the therapeutic possibilities, and provide patient education and access to teams which are knowledgeable in that disease. It would be then a personal testimony that reflects their needs. And this can be done in a visual overview. And we saw the last slide of the first speaker, which was one of these visual overviews. And this is usually supported by a more detailed information matrix. And it shows in an easy way the goals recognized by both patients and clinical experts to be important in that disease. It helps then explain to the patients what is going to be their clinical pathway after the diagnosis, after the shock of diagnosis that we saw in the initial presentation. And they're found to be valuable in sharing knowledge with the clinical community as a whole. This was the initial publication by the members of Eurodis, led by Matt Boltz-Johnson. And we based our study on this paper and also involves Matt and a couple of other people from Eurodis in our study. In another way, we could say that patient journeys are simple ways to complete the view of the clinician on a specific disease and explain it to the patient if they wish. We also heard in the first presentation that some patients consider they've had too many explanations and too much information, and that is not good either. But with these patient journeys, it facilitates the discussion of information between clinicians and patients, and not only on the medical aspects, but also including emotional, psychological, social, and other issues that are important for the everyday life of the affected patients. And in a way, it enables the discussion to identify, as I've mentioned, unmet needs or gaps that deserve to be improved. And these are, as we will see, usually quite common for groups of patients, but also in the individual subject or family. What Eurodis considered was that patient journeys should be initially based on the national guidelines, but these guidelines, which can be very good on the whole, lack many issues that are important. And sometimes, because of these rare diseases being rare, there is not always evidence-based information available. There are examples in this first publication of theirs of patient journeys in these 4 diseases: the PTEN hematoma tumor syndrome, which also involves Cowden syndrome, hereditary breast and ovarian cancer, Lynch syndrome, neurofibromatosis type 1 and 2, and schwannomatosis. And this is what it looks like. This is the visual patient journey in the PTEN hematoma tumor syndrome. And you can see there are these different phases: the disease itself, the clinic, the challenges, and the goals. And then there are different issues for each one of these phases, let's say. First of all, the disease: when did the first symptoms appear and what they were? In this case, the cancer diagnosis, because this is a syndrome that associates cancer, the genetic diagnosis, then obviously the cancer treatment or surgery, and then follow-up and family planning, since it's an inherited disease. This would be on the disease, then the clinic. I can't see it. The range of symptoms, and then the involvement of the different members of the team. Obviously, the treatment will be given in the hospital, and then the options for screening, also for prenatal screening, and then the challenges, which are early detection, the consideration of possible cancers that may exist. And as you can see, the different aspects here: personal treatment, also psychological support, and the knowledge that half of the descent, half of the children they may have, can be affected. And finally, the different goals for each one of these challenges. So these would be for this specific disease. And this would be the legend, which expands more for each one of these previously described issues, what one can expect: the range of symptoms, the involvement of a necessarily large multidisciplinary team with different experts, etc. So we were asked to explore the possibility of using patient journeys as an aim within ENDO-ERN. And I must say that when I first heard about this from the involved patients, the patient representatives within the different working packages. I'd never heard about this. And these patients insisted that this was something that we should definitely look at. And it would be a way for these large European networks to connect collective experience and expertise across Europe. And as one of the aims of the ENDO-ERN, to facilitate knowledge to travel rather than the patient having to travel to the different expert centers. And having the possibility of collecting data from different countries in different languages was something that was considered important. So we started looking at it because it hadn't been, nothing much had been done up to then. Within ENDO-ERN then, we considered that patient journey was a good option for the patients since it could connect the functional status after health intervention or treatment, like, for example, the presence or absence of pain or fatigability, the capacity to concentrate, etc., which are for the patient more important than technical parameters that are usually evaluated for the health outcome, like mortality or complications. They want to be able to lead their normal life with as little limitations as possible. And apart from the safety and the clinical effectiveness of the different healthcare interventions, what patients considered more important, or at least as important, were compassion, dignity, respect, unmet needs, gaps, and issues related to social and working capacity. Because, as I said, this affects their everyday life, and this is not always contemplated by the health administrators. So all this, in a way, would be considered as empathy from the healthcare professionals, and providing information as a patient journey document would tend to improve this empathy, be it either the more visual diagram or the brief test, with the aim of reducing suffering. And this could obviously be beneficial all round. So, as I said, this was initiated by Working Package 4, which was Quality of Care and Patient View of ENDO-ERN, proposed by the two patient representatives. On the one hand, Jette Christensen, who is the chairperson of the Danish Addison Association, and Diana Vitali from Italy, who is the founder and president of the Septo-Optic Dysplasia in Italy, and also collected data on different pituitary diseases. And this was done in collaboration with a pediatrician from Stockholm, Anna Nordenström, and myself from Barcelona. And I found interesting, after listening to the first presentation, that the 3 diseases that we chose were among the 4 most frequent, who most frequently answered the questionnaire that was sent out in the first presentation. And I wonder if this is telling us something about the patients with these diseases. I don't know, it's just a comment. So we included patients with acromegaly, Addison's disease, and congenital adrenal hyperplasia from different European countries. And this was the publication in 2022. And we followed the directions of urologist, developing a template with instructions to collect the information from patient groups. And we then translated into several languages. We contacted different patient associations, in a way, those patient associations with which we had more relationship or which we knew would be responsive to our initiative. And as I say, we included these diseases mentioned here: Addison's and acromegaly, mainly in adults, and congenital adrenal hyperplasia, mainly in children. We collected the completed forms on their experiences in a table template, which we'll see in a minute, and we included about 6 patients from each one of these diagnoses. There was a lot of discussion because, especially in Sweden, the possibility of collecting data on patients was a rather sensitive issue, even though they volunteered. But in the end, we got over this. All participants volunteered to collaborate, and they also signed that the data that they were providing was on a voluntary basis, and this was overcome then the problems that the ethics committee in Sweden may have brought up. We encourage the patients to discuss with other patients or with their patient associations their experiences to get a realistic and full picture of what they had experienced. And as I said, they had signed that they were participating and consented to participate voluntarily. And here you can see the different diseases and the different countries where data were collected. For acromegaly, it was in Denmark, in France, in Lithuania, although here we didn't have a translation, it was in English, and in Spain. For Addison's disease, we collected data in Danish from Denmark, in Italy, in Spain, and in Sweden. And for congenital adrenal hyperplasia, in Germany, in Italy, and in Sweden. And this, I'm not going to read through it, but these were the instructions that the patient received, explaining what a patient journey was, and a description of what I have just explained to you, and how we asked them to proceed. And this was the table that they had to fill in. They could make it as large as possible, including as much data as they wanted. But basically, we were interested in collecting data on the stage of the journey in the first column, the timeline, the clinical presentation and the symptoms, the patient and or family needs, and the ideal outcome of or support that they would ask for in the different phases: pre-diagnosis, at first symptoms, at diagnosis, after first treatment or at first treatment, surgery if relevant, and follow-up care. And these are the results in the different diseases. I mean, I won't be able to read through it all, but I have marked those things which I think are most relevant. And interestingly, with being quite different diseases, many of the issues were similar. And this also was clear in the first presentation, where patients often feel they haven't been taken seriously, they weren't listened to, they lacked information, obviously the diagnostic delay, and the accessibility to experienced teams. For acromegaly, obviously the first presentations were the symptoms that we all know, but some of the patients said they felt that something was wrong, but they didn't know what it was, and they didn't seem to be able to transmit to their healthcare providers sufficient information for the healthcare provider, normally the primary doctor, wasn't able to make a correct diagnosis. But there were also some, for me, interesting issues, like less frequently described symptoms, like an unexplained very large placenta, which had been experienced by a patient who was diagnosed with acromegaly 2 years later. So if a gynecologist said, this is a very large placenta, I don't know how to explain it, perhaps one could think of acromegaly. And then my ENT surgeon diagnosed the patient with acromegaly because he saw some laryngeal ventricular hernias, which he had seen previously in another patient with acromegaly. So this is something that is worth remembering. And then the patients say they've had a change in their smile, or even someone who has seen that individual for some time feels there's something different in their smile. As far as patient and family needs, commonly known, years of repeated consultation with no recognition of the symptoms as part of a disease. And as far as ideal outcome and support, they listed in the first place that listening to the patient by all those involved in their healthcare was important for them, empathy, and then empowering patient associations to share their experiences, which can be very therapeutic. This was for acromegaly. As far as Addison's disease, some of the same issues. No understanding by the family. This was from the patient point of view, because they felt ill all the time or they felt tired, and the families didn't really understand what was happening, and so were rather impatient. Non-recognition for some time by the primary healthcare system. The desire from the patient point of view to recover because they had lost energy and just couldn't carry on their normal life. The necessity of explanation on what it means to live with a chronic disease, and then education on physical and psychological aspects was considered a need and not always covered by their healthcare system. And as far as ideal outcome or support, education, awareness, and empathy was again mentioned. For congenital adrenal hyperplasia, here, of course, the diagnosis sometimes was pre-birth by pre-pregnancy or even intra-pregnancy screening. In this case, usually as soon as the patient had symptoms, the diagnosis was thought about and treatment was started quickly because, of course, it's a life-threatening situation. But again, among the family needs, there was an indication that awareness and lack of information were really important, and that the support groups and especially the nurses involved were really important to transmit what it means living with this disease and why they should follow treatment and know what to do, say on a sick day, etc. And as far as ideal outcome and support, again, indicating access to empathetic and knowledgeable understanding groups, and remembering that even though all the information may be given on the first day, usually it's very difficult for them to understand or grasp it all on the first occasion. So repeated information is important during follow-up. And finally, that the importance of not only the doctors and the nurses, the psychologists, all involved in the healthcare, to be accessible for the patients when they need them. From my point of view, this evaluation has led me to these conclusions. We have identified gaps where improvement in the diagnostic delay, in therapy, or in patient education and access to knowledgeable multidisciplinary teams can be improved. And this obviously affects in a different way the different countries with the different health systems. When relevant, identification through screening will shorten the time to diagnosis and prevent some of the initial severe symptoms and possible sequelae. The importance of creating discussion and partnership between patients and clinicians for these rare diseases. And all these findings could then be used within ENDO-ERN to propose new activities, perhaps within the guideline development or in the new strategies, development of patient information and communication material to be made available for them. Analyzing the impact of the disease on patients' everyday life, social, financial, educational, family issues, leisure issues too, to contemplate a realistic expectancy of what it means to have one of these diseases. And this can also help to reduce health costs and not only consider the physical complaints, but also the psychological issues like stress, depression, and anxiety with a patient-centered approach. And although the existing evidence was small to moderate, there does seem to be in the literature evidence that patient-mediated interventions, like we have described here, can improve professional practice by increasing healthcare professional adherence to the recommended clinical practice guidelines. Finally, the common patient complaints of not having been taken seriously by health professionals, family, or friends. Empathy and patient-centered environment, very much appreciated by them. The access to patient information of what it is to be living with a chronic disease and the impact of the disease on their everyday life. And also to provide a more realistic expectancy for both the patients and their environment, since this in the long run can reduce health costs. In summary, patient empowerment with a patient-centered approach of these complex and rare conditions, if they are contemplated, can benefit those affected as well as the healthcare system. And these are the 4 members of the work package 4, which now has changed, but at that time, these were the 4 people. We also involved Eurodis with Matt and Dr. Bihe, and finally, Vincent Omodrou from Marseille, who was with us in Barcelona at the time. He helped us with the French translations of these questionnaires. And I thank you very much for your attention.